want to let everybody know that we're recording this session and it will be available later if anyone's interested in getting that. So as you may know, April is Health Equity Month, and that really provides a great opportunity for us to highlight the disparities that do exist in our community and consider some of the underlying causes while looking for innovative ways to create a more equitable environment where all of our community members have an opportunity to thrive. And so over the last year, COVID's really brought health disparities and inequities to the forefront of our nation's consciousness. And, as we've seen desperate outcomes for Black and Brown in regard to COVID. And with so many resources focused, thankfully, on dedicated to focusing on the disparities that surround COVID, we decided to shift our focus a little to another concerning public health crisis, which is maternal and infant mortality among communities of color. This is our third week of featuring local experts who've given us information about what they are working on and the innovative ways they care for women. And we'll start off today just with a brief overview of what our community looks like in regards to some of these issues. And then we'll give our panelists a chance to talk about what they're working on. And finally, we'll open it up for all of you to ask any questions that you might have of our panelists. So we look forward to another engaging afternoon with all of you. And thanks for joining us. So just to give you a recap of what we've done so far and what is in store, the first week of this series, we started off by just defining the problem around maternal and infant mortality and discussing why it's important. Last week, we talked about what strategies health systems can implement to impact the issue. And this week, we're going to be discussing the role of communities. And next week, we're going to wrap up with a session on what individuals can do. So this series is brought to you by Roper St. Francis Women's Services and our Office of Community Health. Together, we aim to empower every woman to take charge of health care while providing high quality and equitable services. We thank you all for your time today to discuss this important topic. And I always look forward to these discussions and whatever I'm going to learn and take away. There's always some new nugget of information or new angle or way of thinking about things that these sessions tend to uncover for me. So I hope it'll be the same for you. So now we're going to jump into today's topic about what role communities play. So this is a refresher for anyone who's joined us for one of our previous sessions, but I just want to start by defining the topics or the terms that we'll be discussing today. So maternal mortality is defined as the death of a woman during pregnancy, during delivery, or soon after delivery. And we lose about 700 women a year in this country due to maternal mortality. Infant mortality is defined as the death of a child before his or her first birthday, and 6 in every 1,000 births in our country, 6 in every 1,000 babies born in our country dies as a result of infant mortality. So a lot of work to be done. And, the maternal mortality rates in our country are really dismal across the board. Even if you looked just at non-Hispanic white women, if you compare that with rates in other developed countries, the United States still comes in last place. But we're not looking at just white women, we're looking at the full picture. And when we do that, we see that there's a very clear difference in the rates of maternal and infant mortality in Black and Indigenous families as compared to their white counterparts. So next, we're just going to explore some of the underlying factors that perpetuate health disparities in our communities. So no way we're getting out of this conversation without discussing the social determinants of health. And those are the conditions and the environments in which people are born, live, work, play, worship, all of the above that affect our health outcomes and our quality of life outcomes, and as well as our risks. And we know that taking care of ourselves and eating well and staying active, getting the right immunizations and screenings and seeing a doctor when we need to all influence our health. But our health is also determined in part, at least, by access to social and economic opportunities, things like the resources and supports available in our schools, neighborhoods, communities, the quality of our schools, the safety of our workplaces and neighborhoods, the quality of our water, food, and air, and even the nature of our social interactions and relationships. So along with support systems and community engagement, discrimination is also a factor that influences health outcomes. So it's important for us to really realize and consider the role that interpersonal and structural racism has on perpetuating health disparities. And there's even evidence that the stress associated with being the subject of racial discrimination can have serious negative consequences on perinatal outcomes, including preterm birth and infant death for Black families. So as you can see here, the education level of a Black woman has little influence on her risk of pregnancy-related death. I believe Dr. Hilton touched on this the first week, but the maternal death rate for Black mothers with a college education is significantly higher than white or Hispanic women with less than a high school education. And when compared to their counterparts who are also college educated, that disparity is 5 times the rate. So again, a lot of work to be done and a lot of focus to place on this issue. So we're going to look at some of the social and economic factors, see what those factors look like in our community. So according to 2021 county health rankings, over 10% of Tri-County residents are uninsured. And in our latest needs assessment in 2019, we conducted our Tri-County health needs assessment, and 20% of respondents in the Tri-County reported that they were not able to see a doctor when they needed to. So that essentially means that even 10% of the insured population still does not have access to care, or at least affordable care, to see a doctor when they need to. Nearly 1 out of 5 Charleston County residents is experiencing a housing problem, a severe housing problem, and that's defined as overcrowding, high housing costs, which is probably a huge factor in Charleston County, and lack of kitchen or plumbing facilities. So to qualify as having a severe housing problem, you have to have at least one of those issues. So a lot of issues around stability there too. So African American and Latinx community members tended to report lower rates of health insurance coverage, as well as a less, they rated their ability to drive themselves to medical appointments at a much lower rate. So that means that they're relying on public transportation or finding a person who can give them a ride, or even walking sometimes. And our state's maternal mortality rate reflects the national trend, with Black mothers in South Carolina being nearly 3 times more likely to die from pregnancy-related causes than white mothers. And with over half of, as you see here, 52%, so over half of all pregnancy-related deaths occur after delivery. So the need for this ongoing care beyond delivery is very critical, and it really highlights the value of the supportive and ongoing services that our guests will be talking about today. In fact, a researcher at Harvard recently stated that achieving 0 maternal deaths will require improving women's health not only during pregnancy, but also across their lifespan. And things like poverty, racism, and other social inequalities have significant negative consequences on women's health, including maternal mortality. So what opportunities do we have to combat all of this? I've thrown a lot of really hard information at you, but I want to talk about what opportunities we have to impact all of this. And one strategy that's pretty fundamental to any health equity work is engaging in cultural competency training to gain the ability to care for people who are different from you, who come from diverse backgrounds and have different values or beliefs or behaviors. And really one reason that disparities exist in the first place and continue to exist is that we don't always really have a clear understanding of each other. So the practice of cultural humility really goes a step beyond cultural competence, and it's just a little deeper, and it requires a commitment to lifelong learning and a willing spirit to see the other as a teacher, to help us understand what they need, what their experiences have been, and what their perspective is. So by understanding patients in this way, I hope that we will be able to turn the tide on maternal mortality rates in our country. And our panelists today are certainly well-versed in cultural competency and humility. And I look forward to hearing about their approach to working with women in the community to improve outcomes. So I'd like to introduce to you and welcome Dr. Reshma Khan. She's the director of Shifa Free Clinic. And Ms. Tawana Johnson is the owner of Doula U Birth Services here in our region. So first today, we're going to hear from Dr. Khan to learn about the outstanding work she and her team are doing over at Shifa. And then we'll turn it over to Ms. Johnson to share insights about her role as a doula in our community for over 20 years. And I'm sure, like I said before, that they'll both teach us something new that we didn't know before, and something we can take back to our teams and our families and our communities to spread this message even further. So to Dr. Khan and Ms. Johnson, thank you both for joining us today. And now I'm going to stop sharing and turn it over to you, Dr. Khan.
Okay, good morning, everybody. And thank you, Tara and Mandy, as well as Kimberly, for having me on the show, on your program. It's a great honor to be here with all of you. And thank you for all of your time to be here, and appreciate this opportunity. So my name is Reshma Khan, and I'm the director for the Shifa Free Clinic. Shifa Free Clinic is a nonprofit clinic that serves uninsured and those that are 250% below poverty line with our multi-specialty healthcare services. So we have primary care, OB, GYN, dental, mental health, as well as pediatrics and dermatology services. Today, we're going to focus on our OB specifically services. And I myself an OBGYN, and we have 3 other OBGYN physicians who help volunteer at the clinic. We also have an MFM doctor, Dr. Rayburn, who helps with the high-risk pregnancies, at least giving us, the initial consultation before we send the patient off to Roper or MUSC for high-risk consultations. Our OB services, we started in 2017, and it was a very low scale, very small service. We only served like 2 people in 2017 with cautious, and was very scared to start this new OB program. But over years, by grace of God, collaborative efforts of local organizations, our donors, our partners, our volunteers, we have I'm very happy to say that we have a very well-established, robust OB service program. And last year, we served about 121 patients with the total visits of 721 medical OB visits, just OB visits. And this year, we already are reaching almost very close in this few months. So it is growing, and my experience throughout this whole process has been that the need of the service is great. There is a lot of patients that are very hesitant to initially go to a physician. We've been seeing a lot of teen pregnancies. Just as an example, I will tell you, yesterday, I was so sad to see the situation. It was a 15-year-old who came for her first prenatal visit. She was already 28 weeks in her pregnancy. And to add that, she had a previous 3-year-old child. So she had the first baby at age 12. And I talked to the mom, I talked to her, and we figured it was such a sad story that she was raped in Honduras at age 12. And that's where the first pregnancy came from. And the second one, she was from the school, and the mom said the patient didn't want to say who the father of the baby was. And she confided in us, it's a 17-year-old, he's not interested in, taking care of the baby. So now she has 2 children, school. The mom is a single parent, doesn't have any resources, works by herself, and has other children as well. She herself has a lot of issues going on. And talking in details with her, we realized like the whole family needs support. It's not just her, it's not just one person. Her mom is equally affected with this situation. So our services are very comprehensive. We provide the complete care right from conception to throughout the pregnancy. We provide all lab work free of cost through the donation of LabCorp services. We also provide genetic screening. This is for cystic fibrosis as well as Down syndrome chromosomal anomaly through Myriad Genetics. And they also provide us free services to be provided to the patient. We also have in-house imaging services. So the first trimester ultrasound, normally I do the first trimester's ultrasound, but second trimester anatomy scan is done by an ultrasound technician that we have hired. And that also helps us, the patient, to avoid the cost of even getting the ultrasound done. And with the recent partnership with Roper St. Francis, we are very blessed with this partnership that we are able to send our patients to delivery after when they come close to delivery, even for inductions, C-sections, and just consultation. If I have a patient that has a high blood pressure, they come in an office at 180, and I can at least call the Roper St. Francis Hospital and talk to a hospitalist, send the patient to be evaluated and observed, and given recommendations on what needs to be done for the patient. So this partnership is extremely valuable for us and the community, and it is showing great results with prenatal care to provide to our community. After the delivery, we also take care of the postpartum. So we have the patient come to us at 2 weeks, and then again at 4 weeks to make sure everything is going good with the postpartum care. During the postpartum, we provide all the resources. We also have LARC services, long-acting reproductive contraceptives at our clinic. So if the patient wishes for Nexplanon, IUD, anything, or any other contraceptive services, we are able to provide them as well through our physicians and myself here at the clinic. So it is a very comprehensive program. In addition, because of having the mental health program on site, like yesterday, this patient that we saw, we could send her to our therapist at site, and she could talk to that person and take care of the situation in that case as well. So a lot of resources come together to make this program work, and we are just very happy to be able to provide all these services.
Thank you, Dr. Khan. I think it's great overview of what you guys are doing over there at Shifa, and I think it's really clear the role your clinic plays in providing care for people who, a 15-year-old at 28 weeks without prenatal care. It's sort of hard to even wrap your head around that, and so it just really highlights the magnificent work y'all do. So thank you for that.
Thank you so much.
And now we'll turn it over to Ms. Tawana Johnson to give us some information about what she's working on.
Good afternoon, you guys. As a doula is a person who supports mom throughout their pregnancy, throughout their labor, delivery. We try to combat medical interventions. So we're working with moms to try to lower the mortality rate to prevent maybe C-sections happening. We're educating them throughout their pregnancy. Some moms, first-time moms, they have a lot of questions. Some providers might, be willing to answer a lot of questions for moms, and then some have been dismissive. So that's where we come in, because they ask, they might not know, and we're able to break down and give them the information that they're seeking, all fact-based information, so that they're, well educated throughout their pregnancy. During birth, We do massages, we do different techniques while mom is laboring to help them along throughout labor, to give them some comfort. They might not have a support person, so we provide that support services for them. Some are just by themselves. Some might have, someone that is a support person, but doesn't actually provide a lot of assistance. They're not hands-on. We don't want to take away from dad being there. We also educate dad on how to help mom out. This is what you need to do. I want to include you in so that you can make mom feel a little bit comfortable while she's, going through her labor. Even in the postpartum period, we come into the home. We want to make sure that mom is good. Her mental space is really good. Make sure she's taking care of herself. We're that shoulder that she needs to cry on. She needs to talk. She needs to vent. We're there the entire time, giving them as much support that is needed throughout the whole entire pregnancy, even during the postpartum period, which is very important. Sometimes there are extra services that are needed, like postpartum care, where it could be 6 weeks, 8 weeks after birth, maybe a couple months in after birth, where mom says, hey, I need the help. Can you, give me the assistance? We want to make sure that mom is healing correctly, that she's getting the rest that she needs. So we're stepping in, we're doing light housekeeping, we're assisting with baby, we're helping with breastfeeding. Anything that mom needs, that's what the doula is there to assist with. Is there any questions?
Hey, this is Rick Foster, and both of you, just wonderful presentations. And thank you so much for all you do. And Dr. Khan, it's good to see you as well again. But on the doula front, I think that doulas provide an amazing service. And unfortunately, I feel like in South Carolina, we're not taking full advantage of the role of the doula as part of the team providing care for moms and babies. If you could have your wishes, what would you like to see different? What would you like to see as far as changes in the system and relationship with OB practitioners that help doulas be more involved in the overall process? I don't want to put you on the spot, but I think it's important for us to hear what could we be doing differently.
It's important that more providers support the role of a doula, because I know I've run into some providers that they say a doula isn't necessary. You don't need a doula. Well, yes, you do, because the nurse isn't in the room while the patient is laboring. They might have questions. A doula is there the entire time. The doctor, he comes and goes. He comes, checks, and he's on his way. Nurse comes, checks, she's on her way. A doula, we're there the entire time. We never leave the patient's side. So a doctor supporting the role of a doula, we're helping you guys out. We're helping the patient out. We're making sure that they're confident, all their questions are being asked and answered. We're advocating for them, and we're helping them advocate for themselves as well. They might be nervous and scared to ask. We're giving them a little courage. Hey, educating them. These are the things that, you need to ask and be concerned about your own healthcare as well.
Tawana, I'm just piggyback on you, since I have a history as a doula, now as a labor and delivery nurse. I think, and I'm sure Dr. Foster, you know this that I'm getting ready to say, but what is particularly amazing about having a doula is it is somebody safe, that, as Tawana said, for you to ask questions. You get, evidence-based information from them. It's somebody that's with you throughout the whole thread, your pregnancy, your labor, and your postpartum. And so it's just another set of eyes that are able to see potentially where things may be going wrong, right? And could, guide their clients in, say, I'm concerned, you know, you have this sudden swelling, or you're telling me that you're seeing stars, or whatever it is. You know, a doula is somebody that's had their eyes on them the whole time, that's able to notice those differences and potentially then refer them to, you know, a medical professional to seek the care that they need. And I always, when I was a doula, it was the one thing that I always found so unique was just that I was the sole thread that was there, beginning, middle, end. And I think that's really important.
I agree.
Absolutely.
Sorry, my computer froze when you finished your presentation, Tawana. But I love the advocacy and support you provide women. And I think to kind of go off of what Mandy was saying, it seems like you're providing sort of a continuity of care because you, like she said, that you're there from before, during, and after. And so, you know, you really are a great person to help other people understand what a woman's going through during all of that.
Richie has a question. Thanks, Richie. The difference between midwives and doulas, a lot of people ask because they say, oh, you're the one that delivers the baby. And no, a doula does non-medical. So a midwife is who does everything medical. She does the prenatal visits. She does cervical checks, ultrasounds. Doula does non-medical. So we just assist the patient non-medically. Our role does not involve any cervical checks. We don't do blood pressures. That is beyond our scope. And yes, we would like to see insurances play a role in covering these services. Because right now, the only insurance that is covering doula care right now is TRICARE. And that is something that is new, that TRICARE is now offering doula services under their provisions. But I've seen where Medicaid has been talking about it. But if doula service could be covered, I think a lot of patients would ask for and want to add that, you know, to it to see the benefit of having a doula.
I would say that, oh, I'm
ahead.
sorry. I was just going to say, I would say not everybody, of course, has access to an HSA or FSA. Doula services are covered by those, by most of those. It is acceptable to use those funds to pay for a doula, but again, it's not something that everybody has. So I think having Medicaid come up and start stepping up a little bit in that arena would be huge for sure.
Yeah, I hope TRICARE leads the way on that, and what an opportunity that would be to impact this disparity if Medicaid were to pick it up. So Simone said, as another doula, she'd like to see increased access to doula services, insurance coverage, and increased partnerships between doulas and health systems or healthcare providers. And Kim had a question for Dr. Khan. How are the services of SHIPA covered? And how can the community support your efforts?
Yeah, so we only work through donations, grants, and in-kind donations of the collaborators. So most of our OB services are covered by the collaborators. For example, the lab work is covered by the Lab Corp, and they provide us complete services. The genetic screenings are covered by Myriad Genetics. Ultrasound is what we pay for the patients as we hire the technician. We have an ultrasound machine on site, so it's not too much of a cost for us. And providers are volunteers, so that's how most of it is covered. But definitely we work through donations and grants.
And I don't know if you still have any of this. You didn't talk about this program that you offer, but if you still have the meal donation or meal delivery program, that's another way people can be involved too. They can volunteer to deliver things for your programs. So I just want to throw that out there.
Sure, yeah. There are so many other programs that we offer at the clinic, but I just wanted to focus on OB. I think that's why I didn't mention all those.
Okay.
Yeah.
And Sarah said, we also need to advocate with insurance companies to pay for doulas as preventative care providers, and midwives need to be covered under insurance too, as they are key to healthy outcomes. Michelle saying the first time that she heard about a doula, this was the first time she's heard about a doula, so that's really cool. Do you partner with certain practices, Tawana, And how would a woman know about the services or find out? So any
I
partnerships?
don't practice with any particular practice. I'm independent, so the clients come to me. I work for the client, not the hospital, not the birth center, strictly for the client. So that means I'm advocating for you and you only. The hospital doesn't have anything to do with our relationship. The birth center, the nurses, the doctors, is just me and your relationship. And to find a doula, there are many doulas in Charleston. You can Google it. There's the Professional Doulas of Charleston, where you can go to the Professional Doulas of Charleston website, and there's a list of doula services. There's another doula on Miss and that's Birthing with Purpose. Birthing with a Purpose. She has a doula service, and also community doula services as well. So there are a lot of different services offered in the Low Country.
I think, you know, it almost pains me to know that some people haven't heard of a doula at this point, but it's understandable. I guess it's just been in my world for over 20 years. But it would be helpful too if providers said, like, we know that doula support can increase your your satisfaction with the birth, as well as decrease your risks of morbidity and mortality, right? I think getting providers on board to really make those recommendations would be helpful too.
Mm-hmm.
I mean, and on that note, someone's asking about how, if there's any training to become a doula, if there's a certification process, and if so, like, does TRICARE, do you know if TRICARE requires any sort of certification? Do you want to?
There are lots of doula training organizations that you can go through. There's DONA, there's International Doulas, Madrilla. The list goes on. If you Google the search doula certified organizations, a list, and you can just choose from the different organizations to become a doula. Once you take the course, then you have to have 3 certifying births. Most of them require 3 certifying births in order to actually become certified. And TRICARE, you have to submit your certification when you file a claim. So once you file the claim, the doula usually have to have an NPI number and file the claim along with their certification certificates.
Great. Well, that's exactly what we needed to know. And then some other folks were asking about how to find out about it. We kind of talked about that before. Someone gave, I think you said, the Professional Doulas of Charleston, you mentioned. And then Simone gave us a couple of other resources with
Doula Match is a good one. Yeah.
And National Black Doula Association. Yeah. So
yes.
Great. It's another question from Kim. So this I could imagine could be to both of you, but what are some of the barriers you face outside of insurance coverage, and how your services are perceived by the community and other healthcare professionals? Any stigma? So I'm wondering, for Dr. Khan, are you seeing that people feel some sort of stigma by showing up at a free clinic? Or I've seen you in action. I know that if they felt that way, they won't feel that way within 5 minutes of being in your office. But have you encountered that? And Tawana, same for you, any stigma that you encounter? Kind of touched on it a little bit, but I'd like to hear about that from you guys.
The challenges that we face mostly are translation services. We serve 80% Hispanic population. I would say 80-90% of them are Hispanic population. And so language is a very big barrier. The other issues is transportation. Sometimes people are not able to make for an appointment because of the transportation issues. Those are very, very major challenges that we face throughout, and we try to overcome those in a couple of ways. One, we have on-site translators sometimes available, I would say most of the times. Other times, we also ask the patient to have a translator on phone so that that can be helped. Initially, when I started the clinic, yes, it was a very difficult challenge to get the patients into the free clinic because people were kind of scared. They didn't know who like if this was good enough, like if they would get the standard of care at a free clinic as compared to others. But over the years, the trust has built up, and we have seen our patients stay with us and new people coming in through the word of mouth. So I don't feel that that is a stigma as of, for our clinic and for any other free clinic, I would say, because I think most of them, they do a good job by treating the patient well with compassion, dignity, and making sure that they are felt at home.
I think as the more things you've brought into your practice and your clinic, the other additional services, really, they're probably receiving even better care than most primary care offices because you have all that wraparound in one place. So that's really great support you're providing. How about you, Tawana? Any thoughts about how you're perceived in the community and in healthcare circles, or any stigma you're facing?
A lot of times people think that doula services are really expensive and they are non-affordable. So I try to make the services affordable to anyone because every woman deserves to have a doula. Whether we barter the services, I do a payment plan, I do a sliding scale. So I want to make it so affordable that everyone can have those services if they need it. I also do community doula services for those that are teenage moms, which I offer my services for free because those moms need the doula services.
Oh, wonderful. Go ahead.
Yeah, I wanted to ask a question for Dr. Khan, and then maybe later on I got a comment about the payment and awareness. But Dr. Khan, you kind of touched on it earlier, but could you speak a little bit more about how you're trying to, in addition to providing the prenatal postpartum care services to these moms, how you're trying to also connect them to other community services and resources? Which I think we all know that there are such a broad range of issues that these moms are facing. And so could you talk a little bit more about how you're trying to actively connect to other types of community resources for these moms and families?
Yes, so Dr. Frost, it's very nice to see you. It's very good to, after a long time I've seen you and you look great. Yeah, so we do have a lot of other resources. Every patient, we also connect them to the WIC, Women, Infant, Children program, so they can, benefit from that resource as